Is the sound better? Can someone turn on their mic and let me know?
Yes, ma'am.
Yes.
Yes, ma'am. Better now.
Okay, proceeding. I'm glad that we sorted that out in the beginning. So, moving on. Let's look at the first image. What do you see here? Do we have any volunteer for the radiology? Anybody?
Assalam.
Yes,
Walaikum
okay.
salam, Dr. Sana.
First, should I start?
Yeah, you should.
Okay. This is a MRI T1 weighted image axial section showing a hyper intense lesion at the level of the brainstem.
Is
more
this T1?
specifically,
If this
CSF.
is T1, then what is this?
This is T2.
Okay, yes,
The
this is flare. And there is a very good link here, but okay, go on, go on. This is flare. That's okay. It's a difficult section to recognize.
Okay. And showing an hyperintense lesion at the level of the bones and extending from the bones to interiorly and compressing the fourth ventricle. And
So this is an
there is
intraventricular lesion or this is an extraventricular lesion? What do you think? What is your first impression?
this is I think so extraventricular.
So where do you think this is originating from?
From bones, or it is causing compression on the bones.
Okay, so I would just very quickly read this imaging. This is an axial
Okay.
flare and showing the posterior fossa lesion, which is hyperintense on flare. And we can see that it is causing significant compression over the pons here. And we can see that it is also displacing the basilar artery towards the opposite side. There is, just a minute, there is perilesional edema around here. We can see that the fourth ventricle is displaced. So the lesion is originating, if you can see, this is from the floor of the fourth ventricle, right? And then this is crossing the foramen of Lischka laterally, and this is going in a CP angle. If you see, this is a midline lesion, which is then extending up to the CP angle on the right side, right? So these are can you see my cursor?
Yes.
So this is an axial section, T1 post-contrast image. It is showing the lesion in the corresponding location. This is diffuse, not well circumscribed. There is patchy contrast enhancement. And yes, there's significant mass effect on the brainstem. There might be some infiltration. We cannot be completely sure on this limited image. Whenever you are not sure about a particular finding, you can let them know. Anybody who has asked the question, that the imaging is very limiting and I cannot comment completely whether
Your voice is breaking, ma'am.
My
Excuse me,
voice.
ma'am.
Yeah.
Your voice is breaking.
Oh, it
Your
should
voice
be.
is
My voice is
But
breaking.
it's clear now here.
I think Dr. Mustafa, there's something wrong over your side. Does anybody else has any problems? Because I'm practically sitting next to my modem. There shouldn't be any. Is it clear?
Yes, ma'am. Yes, ma'am.
For
Okay.
me, it's clear.
Okay, okay. I think it was probably a problem over your end. That's okay. So, whenever you find an imaging where you cannot be 100% sure where the problem is, you can always let them know that because this is limited imaging, I am limited in my interpretation as well. This is a midline lesion which is extending on both sides, but more extension is towards the right side. It's going towards a CP angle. It is also displacing brainstem. Basilar artery is also displaced here. And we also see a phloid here as well. And on FLAIR, we see perilesional edema and patchy contrast enhancement on T1 post-contrast. So this is the first image. This here is the second image. I am regretting the links I have put because it has shown you the diagnosis. Otherwise, this was a very atypical imaging. I was very sure that it would give a lot of people some tough time. So we see that we have this hyperintense lesion, and this is T2 weighted sagittal images. Can you all see how diffuse this is? And if you look at it from the mid-sagittal section, it might look as if this is completely infiltrating the brainstem, but that is not the case because the lesion has displaced the brainstem away from the midline. So the mid-sagittal section is only showing as tumor. It's not showing brainstem. So always correlate the sagittal section and the axial section both. If you see the same lesion on the axial here, you see that brainstem is completely displaced opposite to the lesion, and mid-sagittal is showing complete tumor in the midline, and that is what was confusing you here as well. So, as you all know, this is a posterior fossa ependymoma, written over here in the link that I added as a reference, just because if somebody wanted to follow up on this case presentation. This is another very interesting imaging. This is a CT brain plane axial section showing a relatively well circumscribed supratentorial lesion with a lot of calcifications. And there's significant perilesional edema. You can see the vasogenic edema here. The lesion is paraventricular. It is in the vicinity of ventricle, but there is some intraventricular component as well. And when you see the sagittal section, this is T1 post-contrast. You see that there is patchy uptake of the contrast. There is some regions which are hyperintense. The lesion might be solid cystic in appearance, and it's causing significant level of edema. If you see the entire frontal lobe and the parietal lobe, even extending up to the occipital lobe as well. So we see the same lesion on T2 weighted images, and here we can see the extent of edema and some form of intraventricular extension as well. So on this imaging, the safest bet is to not say that this is completely intraventricular or this is completely extraventricular. You can say simply, especially if you're sitting in an exam, that it looks like this is a paraventricular lesion. There might be intraventricular component, but I cannot comment on a limited imaging. So, what do you see here? Can someone else comment on the radiology?
Okay.
Assalamu alaikum, Dr. Hussain.
Assalamu alaikum.
So, what do you think? What is A?
On the right side, I have the MRI post contrast shows the fourth ventricular enhanced tumor, solid and cystic component with extension to the right CB angle.
Okay.
In the middle, this is T2 axial image showing the same lesion with with perilesional edema. In the left side, it's T1 without contrast. It's
This is T1 with contrast, T1 post contrast, C and D both.
At the left side.
Yeah, on the
it's
left
T1
side.
without contrast. Yes, it's T1 without contrast, showing the same lesion with heterogeneous signal intensity. It's a fourth ventricular tumor with enhancement with both cystic and solid component, with extension to the right CB angle. With
there is extension to the right CB angle.
Yes, with mass effect, the fourth ventricle, and I think there's extension to the petroclival junction. It's not.
Yeah, that's right. There is extension to the petroclival junction.
Yes, it's not very clear for me, but I think it is.
Yeah,
So
if you can see my cursor, this is where the petroclival extension is happening.
yeah. Okay. In this section, if I may, in the exam, I would like to, in the 2 years old, excluding that the diagnosis already mentioned that it's ependymoma. I would like to see the upper sections of the axial because it's likely the patient is hydrocephalus.
Exactly,
Other
that's
than
brilliant.
this, yes, other than this, I will put medulloblastoma in my differential diagnosis.
What other differentials would you like to keep apart from medulloblastoma?
Other differential in the fourth ventricle with CB angle. I cannot think much with this
Yeah, because
lesion other
if
than
I had not I'm sorry to interrupt you, Dr. Sen. If I had not added this little line here as a reference, and if you had just seen the image, it would have been very hard to understand that where this tumor is originating from, whether this is originating from the petrous ridge, from the CP angle, from the petroclival junction, or from the floor of the fourth ventricle. So in these tumors, the origin, for us to comment on origin safely, we need multiple sections, especially coronal sections and sagittal sections, because axial imaging can be very, very misleading here. And apparently, if you look at where my cursor is, this gives a very good impression of it being an extra-axial lesion, right? Because this is a well-circumscribed lesion, patchy enhancement. There's broad base on the petrous ridge. There's petroclival extension. So one might confuse it for extra-axial lesions as well. So it's really important when you see an imaging to correlate all the sections and to also correlate the age group. So, but your point was excellent that when we get such imaging, we need to see the supratentorial compartment and rule out hydrocephalus, which is going to be a lot more problematic in the short term than the tumor itself. Okay, somebody has commented arachnoid, epitomoid, dermoid, hemangioma. Yes, that's right. Hemangioma, meningioma can be one of the differentials in these kind of imaging, any atypical meningioma. And hemangioma can be, but for hemangioma, hemangioblastoma, I'm sorry. For hemangioblastoma, we see a lot of phloids around. And piloastro may be a rare differential. Whereas to dermoid and epidermoid, yes, they can be, but they are usually T1 hyper intense. So if they're iso intense or hypo intense on T1, it's less likely to be a dermoid or epidermoid tumor. And why is that? Can somebody comment? Why is that?
Because I see, I wouldn't put the dermoid or epidermoid in such
Okay.
lesion. Excuse me for interruption if I am making any interruption. I wouldn't put the dermoid or epidermoid.
Yeah, right.
Firstly, because the nature, the radiological appearance of this lesion, usually the dermoid or epidermoid, they are well circumscribed lesions with same component. Apart from epidermoid, the epidermoid it's likely to be off midline, so that keep dermoid. The dermoid will not appear with this radiological appearance in this place.
Yeah, you're
It's
right
more
about
like
that.
yes.
Sometimes if dermoid has a lot of other components as well, then it might have this heterogeneous looking appearance. Sometimes, but not always. But what is the one feature that goes against dermoid? A, this is not hyper intense on T1, and B, this is paramedian. This is not median. Dermoid is usually in the midline. Epidermoid is usually paramedian or off midline. So, moving on, we have ependymomas. And next time I might put the links towards the reference articles at the end of the presentation so that you people don't end up getting hints.
It's best if you hide it.
Yes, I am thinking too. I just assumed that the writing was so small that nobody would notice, but I didn't see it in the full screen. So that's completely okay. It was still a good discussion. So moving on, we are going to discuss ependymomas today. They are one of my favorite tumors because they are easy to understand, easy to remember as well. Their classification is easier. So, ependymomas is roughly 8 to 9 different types. They vary from WHO grade 1 to WHO grade 3. There is only one WHO grade 1, that is subependymoma. We are going to come to the classification later, but I am just mentioning here. So subependymoma is the only one which is grade 1. Previously, myxopapillary ependymoma was also a grade 1 tumor. But now it has been upgraded to grade 2. Why? That's a very good question, but we will discuss it later on. So these classifications are both based on the anatomic locations and the molecular alterations. And if you were ever asked how are ependymomas originated from, they are derived from radial glial cells. And these cells are mostly in the proximity of ventricles, but sometimes there might be embryological rests which are spread around the entire CNS. So the usual location is, yes, periventricular or inside the ventricle, but it can occur in hemispheres and etc. And I am making an emphasis on this because I was asked, why does myxopapillary ependymoma occur outside the central canal where there is no ependymal cells? So did somebody say anything? Please mute your mic. I see some new names. I would be very happy if you can mute. Okay, so this is the classification. Pretty easy, pretty straightforward. You have to remember 4 main groups. What are the 4 main groups? The supratentorial ependymomas, the posterior fossa ependymomas, we have the spinal ependymomas, and we have the subependymoma, which is a separate group because it is the only one that is grade 1. All of the others are grade 2 or grade 3. Supratentorial ependymomas can be divided into 2 main categories, and whatever leftover we have goes in this, NOS and NES, okay? Supratentorial ependymomas can be divided into ZIFTA fusion positive, YAP1 fusion positive, NOS, and NEC. The sooner you start pronouncing them and saying their names out, the sooner you are going to remember all of this. Otherwise, it will just evaporate off the top of your head. So, posterior fossa ependymomas, they can be divided into 2 classes, group A and group B. Easy. Spinal ependymomas, one of them is the classic, the easiest to remember. The other one is mycin amplified. This one is bully. This one gives the patient a tough time. Spinal ependymoma, mycin amplified. Then we have myxopapillary ependymoma, which was previously grade 1, but now this is grade 2. Please remember this because a lot of older textbooks that we read end up classifying this as grade 1 still, but this is WHO grade 2 in CNS 21. And we have subependymomas, which are completely benign indolent lesions, grade 1. We are only going to do the supratentorial ependymomas today, and we will cover posterior fossa, spinal, and subependymoma in the later sessions. I don't want to make this an overload of information so that it's easier to retain. So, supratentorial ependymomas, the most straightforward, the easiest to remember. This histology slide is here only because it looked pretty to me. I was curious how ependymal rosettes and pseudo-rosettes look, so I went and searched up the histology during my exams and I found them very pretty. So what happens is the tumor cells align themselves around a blood vessel and it ends up looking like a very pretty flower or rose. And these are called ependymal rosettes or pseudo-rosettes. Those of you who are going to appear in your theoretical exams, if we have any of them, then this is an important histology to remember. Otherwise, it never comes up again, probably, if in your life. So we have ZIFTA fusion positive. We have YAP1 fusion positive. What is NEC? NEC is when the genetic analysis has not identified a gene that involves either ZIFTA or YAP1. When neither of these is involved, then we say them not elsewhere classified. And NOS is not otherwise specified. This is something we label when the genetic analysis has not been done at all. It's not feasible, it was not successful, or it was not available. any of the situations. So the main two categories are this: whatever leftover is there, it goes in this. They can be grade 2 or grade 3. How do we define whether this is grade 2 or grade 3? They get differentiated on behalf of abundant mitosis and microvascular proliferation. Necrosis does not play as important of a role. So is everyone with me by this point? Or it's flying on the top of your head?
Yes.
You're here.
Yes, ma'am.
Okay, so moving on, we are going to do the Zifta fusion positive first. You don't have to remember this. I just wrote it because I found it important. Zifta fused with Rela. If you can remember, good enough. If you can't remember, that's okay. But remember that Zifta likes, because it's FTA, F, it's frontal. T you can ignore. So they are lesions that like frontal or parietal lobes more. Why is that important? Because when we are going to do the YAP1 fusion positive, we will realize that they are lesions which favor the lateral ventricles, or they are either paraventricular or they are intraventricular. So Zifta can sometimes be found in thalamus, hypothalamus, third ventricle, or extraaxial locations, but that is very unusual presentation. Also, they are more common. They are also common in adults, pediatrics, both. They are more common, but they have worse prognosis. So this is how a typical image for Zifta fusion looks like. These are supratentorial tumors. Now, when you see a supratentorial lesion like this, I am very sure that ependymoma is not the first thing you would think of, would you? The first thing that you would think of would probably be gliomas, diffuse gliomas mostly. But when we are looking at pediatric neuro-oncology, ependymomas are also a very important differential to keep when we are looking at supratentorial tumors. The tumor is solid cystic in appearance. We can see some phloids here. We can see the cystic component here. This is the ADC map. And sorry, this is DWI. This is not ADC map. I keep forgetting. Can someone just reassure me if this is ADC or DWI? I think it's ADC. Anyone? Or is everyone just as bad with them?
This is ADC, yes.
Yeah, this is ADC. Thank you, Dr. Sen. I'm
This
very grateful. This is ADC map.
ADCs.
This is showing some diffusion restriction, but not much. Lesions which show diffusion restriction are whitish on DWI and darker on ADC map. So we see some dark component here, but we also see bright components here. This is a mixed presentation. On post-contrast images, we see heterogeneous contrast uptake. Okay, there's some cystic portion here. There's a solid portion here, and there's some mass effect, but the lesion is relatively well circumscribed. So, as I said, these are more common, but with worse prognosis, which is not exactly a good news for our patients. And who remembers this famous...
Excuse me.
Yeah.
Doctor, how frequent the supratentorial ependymoma in pediatric will affect the optic pathway?
Optic pathway it's
Yes.
rare. It's very rare. For ependymomas, it's rare. Usually, the optic pathway gliomas are pilocytic astrocytoma in the origin. There can be other subtypes, but they are very, very rare.
Yeah, but if it can be originated from hypothalamus, for example, and
Yes, it can be. It can originate from hypothalamus.
Invading the optic pathway. It can be
Yes,
with this
it can.
scenario.
It can. If it is originating from hypothalamus, it can invade the optic pathway as well. And that is why there is a subgroup of clinicians who prefer biopsy in optic pathway gliomas, because not all of them are pilocytic astrocytoma. But it's rare. It's very rare.
Yes, because I'm saying this because we faced it twice
Oh,
in our
okay.
practice.
That's interesting to know.
We faced this presentation twice. Yes, so
Yeah.
we so we had to to go out during the surgery and inform the father that it should be taken the biopsy rather than taking out the entire tumor.
Entire thing out, yeah.
So gratefully, in the histopathology, they came up with ependymoma. So it gone well after that with radiotherapy or some sort of further tumor. I don't remember that we go to operate on this a second time. Is
Yeah,
there
that's a very interesting presentation.
uh,
Tumors in the pediatric neuro-oncology can be very, very deceiving. You go in thinking something else, and then operatively you are going to face sometimes something completely different. So yes, it's important to remember the rare presentations, because then they help you in thinking on your feet and guiding your clinical decisions. Good thing is that you have the pathology available readily, because in a lot of setups that we are working in, we don't have pathology before, during the surgery. We don't have frozen sections. So the job is just made a tad bit difficult. So moving on. CDKN2A and CDKN2B homozygous deletion. I think every one of you would remember this deletion now. These are notorious wherever you find them. The tumor is aggressive, and they are an independent poor prognosticators. So you can also find them in ependymomas, which are supratentorial. Moving on. We have YAP1 fusion positive. You don't have to remember this. I put this in YAP1 fused with MAM-LD1. I like to pronounce it this way so that it's easier to remember. Anybody who has been watching news recently can link it with Mamdani. You will not forget it. So YAP1 is fused with Mamdani. I think I would have to mute that out during the YouTube upload. But they are found within or adjacent to lateral ventricles often, and they seem isolated to children. Supratentorial ependymomas, which were ZIFTA positive, they can be found in slightly older age group. YAP1 is confined mostly to children. So look at a very interesting supratentorial presentation. I don't remember who asked me a few sessions ago that whether we have supratentorial tumors in children. I don't remember the question, but we do have some very interesting tumor presentations in the children as well, which are supratentorial, but they are rarer in comparison with the posterior fossa tumors. So this is T2, coronal sections, a mixed intensity lesion, solid cystic variant. There is significant involvement of the midline as well. There's some midline shift, mass effect, effacement and involvement both of the ipsilateral lateral ventricle. If you see the same lesion on the T1 post-contrast sagittal sections, you can see the cystic cavities which are here. You can also notice that the contrast uptake is very patchy. And even though the contrast uptake is patchy, this still can be a grade 3 lesion. So on C, this is an axial section post-contrast, and you can see that lesion is extraventricular. I like to call these paraventricular, but it is also invading inside the ventricle, and the same corresponding lesion on D. This is a T2 weighted axial section showing a large cavity, some solid cystic appearance here, and we see the lateral ventricle. Surprisingly, there isn't significant edema in this. So this is another appearance. Oh, and this is DWI. This is ADC. It's a lot easier when they come up in pairs. You see that this lesion is hyper intense on DWI. This is whitish, right? This is not ISO. This is hyper, which means this is showing diffusion restriction. When a tumor is showing diffusion restriction, that usually means that it is hypercellular with small cell bodies, or densely cellular with a lot of cells. So it could be either scenario. This is darker on ADC, and this is SWI showing some blooming, which means either there is some calcification or there has been some hemorrhage in the lesion. This is D, T2 weighted, and axial sections. We see that this is iso-intense, showing some cystic regions as well. The lesion looks relatively well circumscribed, and there is not significant perilesional edema here. So this is the same lesion post-contrast, axial sections. You see that there is some rim of enhancement. The rest of the enhancement is patchy. So these are less common, but with better prognosis. And that's a wrap. Feedback is welcome. Any questions are welcome. If somebody is not comfortable in talking out their questions, they can just leave their message on the group and we can get back to it in the next session. Any feedback, any questions?
Thank you, ma'am. Bundle of thanks.
Okay, thank you.
Oh, Dr. Mustafa, you were very quiet today.
Yes, I'm listening, ma'am.
Oh, okay.
Thank you.
Okay, everyone, that's a wrap. Thank you so much. We will continue this tomorrow, inshallah.
Sorry, doctor, sorry to interrupt. Just wanted to ask the earlier you mentioned regarding ZEFTA, which is related to RELA, and what's that YAP1, which is associated with
MLD1, yes.
sorry, what is the significance of that actually? What does it mean?
Oh, this is not clinically relevant to us. This is molecularly relevant. YAP1 is a gene, MLD1 is a gene. They are fused, and the fusion is important. We name them as YAP1 fusion positive. So when we are saying fusion, that implies that there must be some other gene they are fused to, right? Fusion cannot happen standalone. So the other gene that they are fused to is MLD1. If you can remember the name, good enough. If you can't, then that's okay as well.
Okay. All right. Okay. Thank you.
And the clinical significance is that these are associated with better prognosis. So even in supratentorial ependymomas, if the tumor is ZEFTA fusion positive, the prognosis is going to be worse. If they are YAP1 fusion positive, the prognosis is going to be better. That is why we are interested in the molecular profiles. That's the only reason.
Okay. All right. Okay. Thank you.
Thank you, everyone. That's a wrap. Have a good day. In fact, good evening.
Good night.